on. Our resource panel will start answering the questions. Resource panel meaning being made up of representatives from AIC, MOH, and the protocol subgroup itself. And after the webinar, there will be the second batch of MCQs being released. Do attempt the MCQs because you get an extra CME point. To get the CME point for the webinar itself, please attend the whole 1 hour. And those that can't attend the webinar, the recording will be put on the website, college website. So no worries there. Just one or two more announcements. This Kama Sutra, the CMS Sutra User Survey Cycle 3 is a different one from the two previous cycles that were run. So we do encourage everybody to try it again. But if you've already done this cycle, then you don't have to repeat it. So do attempt the survey because the information that you provide to us is quite important for us to complete the analysis. Right? And without much further ado, I would like to start the presentation. I will give more details on the Healthier SG Town Hall later on towards the end of this webinar, but do register for it by scanning the QR code. Okay, over to you, Tian Hoa, to start off the presentation.
Thank you, Suraj. Just want to check my sound again. Can you hear me? Can you hear me, Suraj?
Yes, you can.
All right, thank you. Yeah, sorry. I'm using this AirPods, then I got my phone nearby, so sometimes it just jumps over the other side. So apologies, I'm not wired on my phones. Okay. Right. Good evening, everyone, and thank you so much for being here always to host this series of webinars. I'm Dr. Wong Tian Hoa. I'm the president of the college, and this evening we're here to talk about stable stroke. First, of course, I'd like to thank everyone at the Ministry of Health, especially PCC, and also AIC for collaborating with the college to make this series of webinars happen. And I want to thank a whole bunch of people at the background, right? All our experts and who are supporting this series, and all those people who have worked tirelessly in the care protocol work groups, right? Even before all this came out, they've been meeting for 1 or 2 years just to get all the facts and all the details together. And it's really no small feat. I just had this about 2 hours ago. So very happy Chap Kwan Mei to everyone here. It's the last day of Chinese New Year. And to me, it marks the end of all the heavy feasting that we've had, which I think to me began sometime in December. So let's stop eating. All right, it's enough. Okay. So we're doing the Healthier SG protocols on Wednesday evenings. In fact, we did the Tuesday tutorials right in last year. It's the same series, but now we shifted to Wednesday. So I call it the Wednesday webinars. And we had, as a reminder, started off with gout, helmed by Dr. Nelson Wee, and then chronic kidney disease, helmed by Dr. Sharon Shen, and then stable ischemic heart disease by Dr. Kenneth Tan, and last week it was asthma and chronic obstructive pulmonary disease by Dr. David Tan. And we're here this evening, season 2, which I call season 2 episode finale, right? If you look at it, the way I see it is we started from the toe, they moved up to the kidneys, and then the heart and the lungs, and we ended up in the brain. So that's a nice way of wrapping up the series. Everything that I say is referenced, right, from the primary care pages on stable stroke. You can find it on primary care pages, the drop-down menu under chronic disease. You can see it there, stable stroke, right? So we start off with diabetes, hypertension, and lipids, and now we're moving on to another set of care protocols. So you take note that Healthier SG is a multi-year plan, and so there will be, progressively more and more care protocols being rolled out. And really, I think that it's very, very good for primary care because now we have a set of guidelines that we can all, benchmark ourselves and really focus on what's important in primary care and what to look out for. Let's start with the case study. I have Mr. Tan. He's 71 years old, You can see his height at 1.68 with a weight of 45 kg, a BMI of only 15.9, which is on the very low side. He comes in and outside the staff measures his blood pressure at 140/90. He's got a past medical history of diabetes in 2018, hyperlipidemia, and ischemic heart disease. He had a triple bypass surgery in August of 2022, and he's on these medications: aspirin, bisoprolol. He's got sulfonylurea, he's got metformin, he's on SGLT2. And for his cholesterol, rosuvastatin and ezetimibe. Mr. Tan fell 6 months ago, and he was admitted to Sengkang General Hospital and was diagnosed with CVA. He stayed in hospital in Sengkang General Hospital for 4 weeks and was transferred to the ComHos for 6 weeks for rehabilitation. So this is quite a typical case of elderly man, a patient with multi-morbidities presenting with stroke 6 months ago. Mr. Tan works in the insurance line, and some details about his home. He stays with the wife. His elder son is with him, and there's a helper. He does not smoke and does not take alcohol. So he comes to the clinic in a wheelchair, but you note that at home he's able to walk, with no walking aids. But why is he here this morning? He attended the clinic because he fell on the right knee the day before. He was unattended at home. He tried to get up to go to the toilet and he fell. All right, there was no head injury. So he came to see you with a knee injury, I think. Since the stroke, by the way, the wife reported to us that he's somehow lost interest in eating and has lost weight from a pre-stroke of 52 kg 6 months ago and now 45 kilograms. What are your immediate thoughts? And in this case, what do you think are the care goals for Mr. Tan? Let's jump straight into it. These are my immediate thoughts. The first thing that strikes me, of course, is that this is a long case. And if it's a busy Monday morning, it's about 11 a.m., you're looking forward to lunch, you can forget about the idea, okay? Scratch that, right? All your queue is off whack. This post-stroke patient is gonna take at least 20 to 30 minutes of your time, and your queue system is all delayed. So we have a long case. Post-stroke patients present with multi-morbidity. And unlike ischemic heart disease, for example, stroke patients usually suffer from very significant physical disabilities. All the principles of family medicine will apply in this consultation. You're talking about patient-centered care, all right? What does the disease mean to the patient in the context of the patient and his family? Continuity of care. You're going to have to manage the patient over a prolonged period of time, right? 6 months, 1 year, 2 years, over a longitudinal course of time. You need to look at care coordination, not just you, right? You need to enlist the help of other people in the healthcare team, and also necessarily refer to specialists if required. You need to talk about comprehensive care. He's not coming in for stroke. He's coming in for a fall. He's coming in for weight loss, all right? So care is going to be comprehensive. And therefore, in this consultation and in subsequent consultations, all 4 quadrants of the Stott and Davis model will be at play, which includes managing acute problems as well as chronic problems, talking about preventive care, how you're going to modify health-seeking behaviors. What are the care goals for Mr. Tan? I think primarily, because we're talking about stable stroke, you have to try to prevent another stroke, right? So please, let it not happen again. How do you optimize the patient's chronic diseases? Talk about lifestyle modifications and various pharmacological interventions. How do you manage the consequence of stroke, right? Post-stroke sequelae, such as post-stroke pain, things like depression and spasticity. Talk about preventive healthcare and, for example, vaccinations. And then look at family and social support for the patient. And eventually, you have to talk about caregiver support, because looking after Mr. Han is going to be a long drawn affair. It causes a lot of stress to the caregiver. So that's quite a lot. Let's look at the chronic care protocol for stable stroke, which is on the website. The incidence of stroke in Singapore has been going up. It's the fourth most common cause of death in 2021, accounting to close to 6.1% of deaths in Singapore. But if you compare it with the third most common cause, which is ischemic heart disease, is in a region of 20%. So the third most common cause is by a factor of 3 times. Hyperlipidemia and hypertension were consistently the 2 most common risk factors among stroke patients across the years. And diabetes, smoking, and atrial fibrillation flutter were also prevalent among stroke patients. These were significant risk factors. So stroke is basically a heterogeneous disease. There are clear pathological subtypes, if you will recall, such as transient ischemic attack, cerebral infarction, primary intracerebral hemorrhage, and subarachnoid hemorrhage. All these are different kinds of pathological subtypes. The focus of this care protocol is the medical management of patients with stable stroke, and is defined as patients who experience stroke more than 6 months prior to the visit. Rehabilitation is very essential, but it's not the primary focus of this care protocol. Your job as a primary care provider is to identify patients who have post-stroke and make sure that they are undergoing appropriate rehabilitation. And if they're not, then you need to make sure that they are referred to the appropriate care facility. The Singapore Family Physician is a rich resource, right? If you go to the college website, throughout the years, we've been producing all these journals on the SFP. And let's just revise a bit about stroke. And I found 2 very good articles on stroke. The first is Stroke Rehabilitation under the Geriatric Care 2024 series. And the second was the titled The Clinical Sequelae of Atherothrombosis under the Atherothrombosis series. You can search this on the website as well. So let's just revise a bit about stroke. What is the mechanism of stroke? Stroke occurs when a part of the brain is damaged due to lack of blood flow. If the neurological symptoms or signs last less than 24 hours, a transient ischemic attack or TIA is said to have occurred. TIAs typically last a few minutes, and most symptoms disappear within an hour, but they can last for up to 24 hours. TIAs, as we know, are harbingers of a stroke to come. There are 2 big classes of stroke, right? You can divide them into the hemorrhagic stroke, such as primary cerebral hemorrhage from hypertension, as a result of hypertension, right? 24% of all strokes, bleeding from AV malformations, or an aneurysmal rupture from causing a subarachnoid hemorrhage. But this is only 1%. But if you look at the news, ruptures from the brain bleed is usually quite spectacular and newsworthy. So it can occur in very young people, and cause a lot of distress. It can affect anyone. It can affect cabinet ministers halfway through a cabinet meeting, and that occurred in 2018. But just take note that bleeding and rupture is a very small percentage, only 1%. The majority falls under the ischemic stroke category. So it's either thrombotic or embolic. Thrombosis is basically blood clotting and causing obstruction of an artery. Embolic means that a blood clot has formed and has traveled to another site, right? An emboli. A large artery occlusion from cardioembolism, right, from the heart, can cause a stroke, usually with underlying atrial fibrillation. These occur about 10% of the time for all strokes. But the major part, the 40% of the time, is due to occlusion of small intracranial arteries, leading to what we call lacuna syndromes. There are other kinds of ischemic strokes, such as atherothrombotic stenosis occlusion of extracranial carotid arteries, and also intracranial large artery occlusion from thrombosis. What are the signs and symptoms that a patient will develop, right? It will depend on the site and the size of the stroke. So these things can occur, all these clinical symptoms such as hemiparesis, where you have a motor pathway affected on the contralateral frontal cortex or in the brainstem. You can get hemianesthesia, dysarthria, which is impairment of speech due to loss of control of the speech muscles, aphasia, which is the inability to form language or to understand language, hemianopia, diplopia, incoordination, and giddiness. A large stroke can cause severe headaches and even vomiting, and then loss of consciousness. This interesting article on the Straits Times on speech therapy, and this lady is actually treating patients with aphasia, all right? And she describes aphasia as, imagine having to live in a country where you don't speak the language at all. For example, Poland. Everyone around you speaks only Polish. You step into a cafe, you want to order food, but the menu is entirely in Polish. There's no visuals to guide you. You want to talk to someone, but they only look at you and they can't understand you. So that is someone suffering from aphasia. Some common post-stroke complications. You have motor and sensory impairment. The majority of patients with stroke have motor symptoms or signs, 80 to 90%. Somatosensory deficits have a reported prevalence of about 50 to 80%. Post-stroke can cause cognitive impairment and is very common, affecting up to 60% of stroke survivors within the first year after stroke. Don't forget about bowel and bladder dysfunction. They cause significant distress to stroke survivors. Post-stroke urinary incontinence has an approximate prevalence of between 40 to 80%. And bowel problems will also occur, including constipation, fecal incontinence and impaction, and incomplete emptying. Risk factors for constipation post-stroke include impaired mobility, dehydration, reduced dietary fiber intake, polypharmacy, cognitive impairment, and problems with toilet access. Post-stroke depression certainly can occur. Approximately 30% of stroke survivors will suffer from depression and is often underdiagnosed. PSD is associated with poor functional recovery, impaired quality of life, and increased mortality. And pain, post-stroke pain. Reported prevalence can be up to 55% of post-stroke patients. There's central post-stroke pain, which is a central neuropathic pain syndrome occurring after a stroke, characterized by pain and sensory abnormalities in the affected parts that correspond to the injured cerebral area. You have complex regional pain syndrome and shoulder pain. Look out for shoulder pain. It occurs in 75% of stroke survivors, associated with poor motor recovery. And you can imagine if someone has, a one-side stroke with paralysis of the arms, the whole shoulder assembly is held by muscles, right? And that falls down, you end up with subluxation and severe shoulder pain. And that shoulder has to be supported. There's also post-stroke spasticity. Management of stroke. The common risk factors of stroke can be categorized into the following. Those that are non-modifiable, including age, a history of stroke, history of TIAs, a family history of stroke or TIA. But there are also many modifiable risk factors, including hypertension, diabetes, hyperlipidemia, smoking, physical inactivity, diet, and obesity. For cardio, there's atrial fibrillation and heart diseases, hypercoagulable states, and some medications that increases stroke risk. Do note that modifiable risk factors accounted for more than 80% of the global risk of both ischemic and hemorrhagic strokes. So there's certainly a lot that we can do to prevent a secondary stroke after a stroke has occurred. Modifiable risk factors like lifestyle, you look at smoking cessation, obesity, diet management, sedentary lifestyle, and excessive alcohol intake. Smoking cessation has been talked about before. Strongly encourage patients to stop smoking. For those patients who do not smoke, they shouldn't start, and provides counseling and have with you, some of this knowledge, right, of where they can refer for quit smoking programs. The SMA News published a very interesting edition in September last year, and they devoted the whole article, the whole magazine, on smoking and vaping. It's very interesting, and I summarize it for you. In particular for vaping, right? E-cigarettes are illegal in Singapore, but that shouldn't stop you as a doctor from advising your patients, right? I mean, although it's taboo subject, but if they're vaping, they're vaping. E-cigarettes have a higher addiction potential to tobacco cigarettes. There's a greater amount of nicotine dispensed in an e-cigarette. One vape can deliver 5,000 puffs. Therefore, it actually encourages continuous vaping. Whereas when you take out a cigarette, you burn a cigarette, lasting a couple of minutes, and then you take another one out. E-cigarettes contain both nicotine and many harmful solvents. And most worrying of all, e-cigarettes are alluring to the young because of the packaging and the flavoring, and it's a gateway to other substance abuse. How about lifestyle prescription for hypertension? No, for stroke, right? You can look at the prescription for hypertension, which is quite similar. And these are the advice for nutrition, physical activity, and even mental well-being. This is available on the link at the primary care pages. Use the 4A's model, a patient-centered approach to prescribing lifestyle advice. First, ask and understand what the patient's needs and preferences, what they would like to see to change, and how they want to change. And then you give the appropriate advice, right? Identify and recommend lifestyle actions for them to consider. And then you assess the patient's readiness to carry out these actions and help them to create an action plan, a to-do list of how they can change their lifestyle. So basically, to me, is asking the patient to change from within. You can't force anyone to change. Risk factor control, right? For hypertension, in a follow-up phase, blood pressure should be maintained below 130/80. But of course, less stringent targets are appropriate for certain patients, for example, the frail elderly. You don't have to be, it's not a hard and fast rule. For hyperlipidemia, maintain the LDL at less than 1.8 or 70 milligram per deciliter in patient with ischemic stroke. For patients with hemorrhagic stroke, in the absence of other risk factors, you can use the cardiovascular risk assessment calculator to determine the appropriate LDL cholesterol target. Refer to the 2023 ACE clinical guidance for more details. For diabetes mellitus, maintain HbA1c at less than 7.0%, which is your target. Refer to the diabetes care protocol for more details. In terms of medication, you're not expected to start patients on antithrombotics or anticoagulants, but you must be aware that about these drugs, and they're usually started at the point of care when they're admitted to hospital. So antiplatelets is started after excluding the possibility of brain hemorrhage. Stable stroke patients who are not on antiplatelet therapy should be engaged in discussion, explore what are the reasons. These are some of the common medications that are used as antiplatelets, right? The most common being aspirin, 100 milligrams a day, clopidogrel, 75 milligrams a day, an aspirin and dipyridamole combination. The clopidine, 250 milligrams is kind of an old drug. We don't use that anymore, but some older patients are on them. And if they're on them and they're stable, you're not expected to change. Anticoagulants are specifically for patients with atrial fibrillation. They have a high risk of embolism. Warfarin is used commonly. And note that the target INR should be in the range of 2 to 3. But it all depends on the cardiology and neurology input. We also have the newer DOACs, right? The direct acting oral anticoagulants, of which apixaban is the most common and used in the public sector. There's a resource guide for stroke survivors and their caregivers, which is in the link in the primary care pages. Stroke survivors can experience a host of post-stroke complications, which I mentioned. And there's a post-stroke checklist, which is a helpful framework for identifying the needs of stroke survivors. So this is the checklist that is provided. And of course, if you don't have a stroke, there's no point looking at it, right? But if the patient has a stroke, you can provide this for the patient and the family members. And it's a very good checklist to look at, including, assessment of the activities of daily living, assessment of the mobility needs, look out for spasticity, to identify pain, incontinence, difficulties in communication, check for mood disorders, cognition, and even, things like personal relationships and fatigue. Okay, with that, we go back to the case study and let's have a look at what is going on, right? And let's delve in a bit more detail. So, Mr. Tan is coming to see you with a fall on the right knee, right, as the primary complaint. And also, incidentally, you note that he has got weight loss, a significant weight loss in the past few months. He comes in a wheelchair, all right? Why? Because he had a stroke 6 months prior to the visit. He's got a background of multi-morbidity, right, with diabetes, hyperlipidemia, and ischemic heart disease. What are you going to do? Well, first thing is you need to ask Mr. Tan what kind of medication he's on. Unfortunately, many of our patients are poor historians. Right? This is a patient asked to show me his medications, and he digs into his bag and brings out a bunch of pills. Another patient, I asked her to go back to her apartment and show me the medication she's been taking. So she goes upstairs, comes down 10 minutes later, and shows this to me. Right? And we're none the wiser. So all the pills have been, placed neatly into a pill box. So patients generally, in Singapore, may not be able to tell you what their medication list is. What do? I think in this case, it'd be prudent to, take out your mobile phone, log on to SingPass, and get on the NHR. At the NHR, look out for the medication list, check the problem list, check the discharge summary report. For Mr. Tan, we note the MRI brain, which was done, in March, showed acute lacunar infarcts in the right frontal lobe and right centrum, semi-ovale. There's no evidence of hemorrhagic conversion or acute hemorrhage. There are chronic infarcts, chronic microvascular ischemia, and cerebral involutional changes as detailed above. So we have a lacunar infarct as the cause of the stroke 6 months prior. Okay, so we know that the presenting problem is he fell at home. So the first thing is to assess the knee injury and to manage the acute presenting problems. And you're happy to note that there's a minor abrasions, there's no bruises and no joint swelling. You don't think there's a fracture. So what's the functional status? You do an ADL. At home, he's not using a walking stick. So mobility-wise, he's walking around slowly and unassisted. He is able to bathe himself, but with help from his helper. And dressing is assisted, but he can feed himself independently. For toileting, he's using diapers, but allowed to use the toilets if he's able to make it there in time, but he needs assistance in transferring. In terms of cognition, he's able to converse and understand questions, and you're able to talk to Mr. Tan, but the family reports that the patient has occasional confusion. So you do the ADL, you note all this down in your case notes. What are possible causes of frequent falls? It could be due to muscle spasticity or weakness, or just fatigue. Is there a problem with balance and coordination? Or is there a problem with sensation, proprioception, and visual impairment? Could it be due to postural hypotension or as a side effect of the medication? Or simply he fell because there was a slippery fall or a mat or a carpet that he tripped on? These are all the factors that you could explore. Next, let's look at the incidental finding of loss of weight. Wife says she has lost interest and has no appetite. So you open that Pandora's box. Post-stroke weight loss can be due to dysphagia and swallowing difficulties, can be due to immobility and atrophy, and stroke-related sarcopenia, which is a progressive and generalized skeletal muscle disorder that involves loss of muscle mass plus loss of muscle strength, causing reduced physical performance. It can be due to depression, anxiety, and stress, or even social factors such as impaired feeding or caregiver stress. What kind of diet advice can you give, Mr. Tan? A quality diet with adequate caloric and protein intake is a first-line therapy for elderly patients with sarcopenia. Do note that older adults have higher daily protein requirements than younger people. And you can recommend myoprotective food groups, including meats, small meats, fruits, vegetables, dairy products. For plant-based proteins, you can look at recommending peas, beans, lentils, or tofu or soy milk. For animal-based proteins, you can advise more eggs, milk, cheese, lean meat, fish, and poultry. Then we move on to the care goals for Mr. Tan. You want to prevent another stroke. So you have to make sure that you monitor his blood pressure and cholesterol and make sure that your target is below 130/80 and LDL about 70 milligrams per deciliter. Check his diabetic control and the target is 7.0% for HbA1c, and optimize risk factors such as smoking and alcohol, which he doesn't have, diet and exercise. And then you go on to prevention, right? Look at his vaccination history. So he had his pneumococcal vaccinations, Prevnar 13 and 23 given. We do note that there's a new pneumococcal vaccine being approved that was announced yesterday, coming online in September. How's his COVID vaccine and booster? Are they up to date? And you could recommend an annual influenza vaccine. Caregiver support will not be covered here, but the resources are available. Okay. That's mostly for Mr. Tan's case, but I also want to talk about driving guidelines for post-stroke, which is very important and we all see it all the time. What is the advice on the SMA fitness to drive guidelines for post-stroke? For group 1, which is passenger cars and motorcycles, note that patients without any residual disability can resume driving after 1 month post-stroke. But if they have disabilities such as weakness, visual impairment, coordination defects, then they have to go for the DARP, which is the Driving Assessment and Rehab Program at Tan Tock Seng Hospital, 1 month after a stroke, and may be allowed to drive if they pass the DARP. For TIAs, if it's a single TIA, they're allowed to return to driving once free of TIAs for 1 month period. If it's multiple, then it's for 6 months, no driving. It's much stricter for group 2, where they are taxi drivers or hold vocational licenses. If they're able to return to driving, they can only return to driving if all the conditions are met. 1 year post-stroke, and stroke is not due to a high-risk underlying condition, such as severe carotid stenosis or untreated aneurysm. They must be fully recovered. They have to pass the DARP, and final clearance must be given by a neurologist. For TIAs, they're only able to return to driving 6 months post-TIA or 1 year post-TIA if it's multiple TIAs. And the TIA is not due to high-risk underlying conditions. They must be compliant with treatment, and again, final clearance given by a neurologist. The final part, I want to go through the stable stroke recommended care components. For thromboembolism risk assessment, your frequency is indicated clinically. and you evaluate for atrial fibrillation, cardiac murmurs, fasting sugar, and the need for antithrombotic therapy. Rehab's needs assessment should be done at baseline. You need to check the blood pressure at least twice a year, lipid profile at least annually, and smoking assessment annually for smokers, and once off for non-smokers. Although my CMS, every year they ask me whether the patient is smoking or not, even though they're non-smokers. For influenza vaccines, they should be done annually or per season for patients 18 to 64 who have had stroke, and all persons above 65, and we know that. Do note that the pneumococcal vaccines are not indicated under the NEIS for stroke, but many patients with stroke often have comorbidities which qualify them for pneumococcal vaccination. For COVID-19 vaccination, as recommended, under the current COVID-19 circulars, you can read up about that. Okay, and data submission and financing. So we just realized how important this is because recently we had our first payment of the annual service fee, and now everybody's excited to make sure that they know what to submit, what kind of data to submit, right? So things like diagnosis, those with asterisks are compulsory. You need to have the diagnosis. You need to submit the CDMP conditions, right? For blood pressure, you need to do it with the date. You need to log in the LDLs and the date. For blood sugar, only if they're diabetic, you need to check the height and weight and the BMI calculations and the date. For smoking, at least once a year. And for vaccinations, you need to key in the date of vaccination and as well as the codes to get paid for your vaccination service fee. And that's all I have for